All right. Well, I think for the sake of time and to respect everyone's time, we should probably get started. So welcome everyone. I'm Tony Eskander. I'm the chair of the CDMS, and Brittany Barber's my co-chair, who's here. And I really wanted to thank Marianne Abouyarid, who's the one that's organized this session, this virtual tumor board entitled Soft Tissue Reconstruction of All Shapes and Sizes. She has three fellows presenting with three of their faculty. So Nicole Farber's presenting under the supervision of Ryan Carey. We got Andrew Prince with Lindsay Moses and Ben Lancaster with Dusty Silverman. And we have some more senior discussants. We have Maddie Stroll and Jason Lebowitz as well. So I'm going to hand it off to Marianne.
Perfect. Thanks so much. Thank you to everyone for putting their case together, and hopefully we can engage some good discussion. We'll keep it pretty casual, where they'll present one case at a time with their slides, and throughout that, I'll ask some questions. Hopefully, engage some discussion with our two expert panelists, Dr. Leibowitz and Dr. Stroll, and then of course there are numerous very experienced faculty on here that I see as well. So please chime in if you have any comments or questions as well. I loved the topic of soft tissue recon of all shapes and sizes, so I went with the suggested title. And we have three cases for you. I thought we could go ahead and start with Ben Lancaster and Dustin Silverman's case. If you want to pull up your slide.
Yeah. See if I can get it. Is it working?
Yeah.
Awesome. All right. Yeah, my name's Ben Lancaster. I'm the fellow at the University of Cincinnati. Got a case that I did with Dr. Silverman here. So we'll get started. Brief history, 75-year-old male. He had a history of a T3N1 squamous cell carcinoma of his left maxillary sinus. He had a maxillectomy, neck dissection, and reconstruction with an osteocutaneous forearm in April of 24, followed by radiation. And then on just routine surveillance imaging, he was noted to have a new enhancing mass under his orbital floor implant. Otherwise, fairly healthy guy, some hypertension, gout, was a smoker, but had quit decades ago. His exam, his extraocular movements were intact. He didn't have any globe malpositioning. He was having some progressive epiphora of his left eye. He had some numbness of his cheek on the left, which had been stable since his surgery. Well-healed incisions, no teeth, unremarkable intraoral exam, no adenopathy in the neck. Did a scope exam in the office. You can see some friable tissue kind of emanating from that where his left maxillary sinus would be, or what was left of it. Took a biopsy, and biopsy came back as invasive squamous cell carcinoma. Imaging, we've got CT with contrast, coronal and sagittal imaging. You can see some enhancing soft tissue that's kind of creeping up the lateral wall of his left maxillary sinus. And then you can see his orbital floor reconstruction plate as well, with some enhancing tissue, obviously both inferior and then also a bit superior to that as well. You can see that in the sagittal image as well. Some enhancing tissue that kind of creeps along that plate towards the posterior aspect of his orbit. And then here, we have a T1 fat suppressed with contrast MRI, and axial, just again showing that enhancing tissue in the maxillary sinus. As well, something that our radiology colleagues who commented on was an enhancement. Sorry,
My cat does that too for
out of
some reason.
nowhere. Some enhancement of V2 and foramen rotundum on the left. So for surgery, we did, for the ablation, we did a left total maxillectomy. We weren't quite sure, we had a long discussion with the patient beforehand regarding the status of his eye and whether or not we'd be able to save that. So you can see in that first picture, his prior free flap, osteocutaneous forearm. And once we were dissecting underneath that, for the prior surgery, they had put an orbital floor plate that was then secured to the radius, and that had kind of detached from it, and we could see what looked like tumor kind of creeping up through that gap into the orbit and into the periorbital fat. So ultimately did make the decision to take the eye. So ended up with a total maxillectomy with an exenteration, and then in this right picture, it's a little hard to see in here, but the two tines of the forceps you can see inferiorly and more on the patient's right. We drilled out the vidian, and then superiorly there laterally the foramen rotundum, given that MRI findings. His neck, he'd only had a level 1 and 2A neck dissection prior, so we completed his neck dissection. And the prior flap had gone to his left facial artery and external jugular veins.
And then before you click away from this slide, I do know that you have some nice like reconstructive considerations coming up, but I did want to just have these photos up maybe while we talk about this a little bit. I think taking the eye out helps us simplify the reconstruction in a way, just not having to kind of worry about the function and the epiphora that you mentioned. I was wondering if Dr. Leibowitz or Stroll, if you were leaving the eye in a case where you could oncologically, do you stent your nasolacrimal? Like how do you kind of handle that, or what do you expect to tell the patient after, and or do you just not worry?
I don't stent. I send to oculoplastics after the fact, and usually I've asked them, I said, hey, is it good to stent before or after? The ones I work with, they like to do it after radiation. So that's my practice. I just tell patients, they're going to have pretty bad epiphora in the meantime. But in my residency, they used to prophylactically stent, and I didn't think that changed any. I mean, people still got epiphora and all that.
Yeah, especially after radiation too.
Yeah,
I agree. Whenever we do these with the oculoplastic surgeons, they don't want to stent. They deal with it in the future, if at all.
Yeah, I feel the same way. I don't think it's worth the effort. Haven't found that it made a big difference. It's, just another thing then you have to try to pull out later when you're kind of cleaning out the crusting and everything too. If you, I know this is a soft tissue topic, so I don't want to focus on the bony recon there at the rim, but the orbital floor plate that you may put there, any kind of thoughts on how to prevent plate exposure after radiation? Anything any certain flap you prefer to fill that maxillary sinus space to try to prevent that?
I hate putting the orbital floor plates in. I haven't tried this yet, but I've heard people, instead of putting a plate in, like slinging it with fascia. And then I've been leaning towards using more of the resorbable plates, because I find that the patients get a little more, theoretically it goes away with time and they get socked in and don't really need that metal. But to be determined if that.
Yeah. Have you used them yet? The resorbable?
I've used them a couple times, but the patients haven't been far enough out to see if that changes.
And I can't think of a patient over the last 20 years who had a metal plate put in, who got radiated, where the plate didn't eventually work its way out or have to be taken out. So we have stopped using those completely.
Nice. Yeah. I learned that the hard way.
They always come out either through the skin or into the sinus.
Yes. Yeah. I definitely learned that the hard way my first year. And then after basically a year after radiation, he had plate exposed, right under his eye. I had to take it out. Then he had a hole there. And anyway, it's a mess. But I also blamed that I didn't put a robust enough soft tissue flap, perhaps. Like maybe that's why I was wondering if.
Even if you cover it and wrap it with a forearm or something else, especially if there's radiation, it's breaking through at some point.
Nice. Okay.
Can I just barge in? Sis Goner here. 20 years later, I would say I don't have anybody actually 20 years out from a maxillectomy with that, but since I've been using the scapulas, I actually do use a plate, and I have not had any extrude so far. So that's probably 15 years. I mean, I don't have like a million to go by, but I would say that, if you put enough soft tissue in, like with a huge
That's all I was
sort of thing
wondering.
that I do,
Yeah.
yeah, like I mean,
Yeah.
I'm putting in scap
You
and
put like a
lap and
ton of
everything
lat.
else.
Yeah.
I mean, not
Or
really. I leave like a very robust cuff of the kind of periscapular musculature. So subscapularis and teres, I just leave like a ton of it on. And then when I'm closing, I sort of peel some of the muscle up and put it over the plate before I put the skin down. So I'm really super, super OCD about covering it with muscle and everything, not just ever leaving like a random plate. And then the muscle also fills the entire like cavity, and then I have the bone inferiorly. So my scapula bone is really my palate, and then I have the plate superiorly and all of the muscle filling everything else and then covering it as well. So just,
will that give some
that's just
hope
my
for if you do feel like you need that extra support for the orbital floor, maybe going for a scap or something. Again, this is a soft tissue. I don't want to get off.
right.
But I did think it was an important discussion with this case specifically. Perfect. Thank you for bringing that up. And then, Ben, sorry to interrupt you if you want to keep going now with your.
No, that's great. Thank you. Yeah, so considerations for reconstruction. Obviously, we just talked about a big one, whether or not the eye stays or goes. If that's the case, you want to somehow maintain the position of the eye so they don't end up with diplopia. And if you're taking it, something to adequately fill the orbit and obliterate that space. And then ideally want to maintain a patent nasal airway if you can, so they can breathe through that side. And then from another functional standpoint, the ability for dental rehabilitation, if that's in the cards for the patient. And then from a cosmetic standpoint, providing enough bulk that they have mid-face projection that's similar to the other side. Challenges, kind of everything again that we just talked about with managing the globe, if that's still there. Stenosis of the nasal airway over time, a mucocele, obliterating all the sinuses. Gravity, just with time, is the flap going to sag or pull away or end up just hanging in their mouth or in their oropharynx? And then, a consideration for us in this case, this is a gentleman that had radiation, had already had one free flap, so just finding adequate vessels for the reconstruction. So we elected to do basically just a very large ALT to fill up as much space as possible. He wasn't wearing dentures, even beforehand, so didn't go into it with the goal of restoring dentition in the future. So just soft tissue reconstruction was our flap of choice. We started our inset posteriorly into his soft palate and then wrapped that up and around. And then you can kind of see it on this picture on the left. We used a wire passing burr to make a number of holes in the zygoma there. That's the only one you can see, and then would use Prolene to kind of tack the flap up and suspend it there. And then we also did that along kind of they were a little delicate in terms of their hold, but the most lateral bone of what was left of his ethmoids, and we actually tacked the flap to that. We were able to cannulate his frontal sinus and kind of tack the flap with Prolenes to bone that was lateral to the frontal outflow tract. Then we sutured it along the nasal floor to the septum and remnant of the nasal floor mucosa where it still existed, and then all the way back to just in front of the eustachian tube. You could there's a little bit of soft tissue from his tongue in the way on the picture on the right to see that, but that's what we did there.
Yeah, thanks for bringing up the wire passing burr and tacking it up there. I actually didn't appreciate that when I looked at your slides yesterday, but that's really smart just because, as you mentioned, gravity is against us. And over time, I've seen it kind of pull down and you end up, with a new hole in the orbit and they're not happy with that. So yeah, I wasn't sure if and I do see some comments in the chat still about the um, muscle and everything. We can round back out about that if there are more comments too as you keep going.
Yeah. And then I can kind of try to go through this more quickly, but yeah, we de-epithelialized a large portion of it, basically just to where we needed to inset it into his buccal mucosa in his upper lip. And then on the right, we actually ended up elevating this skin on the flap that was here laterally and kind of reflected and rolled that back over and inset that into his nose as an internal lining in hopes to prevent stenosis of his nasal airway on that left side, and then closed him up. Here's just a brief look of it a few days after surgery, and then Dr. Silverman saw him just the other day. He had an uneventful hospital stay. He's doing well at home. Path came back relatively favorable, all things considered, and he's doing well. And that's all I got.
Nice. Yeah. Does anyone have any other comments they want to bring up about this?
I mean, I think that's a great reconstruction. I like how you de-epithelialize and use the skin for the inside or the internal lining. I do think over time that left nasal cavity will narrow out. It will still nose down, no matter how long the stent stays in. But at least you have something. And then what I've been doing, I send them to one of our facial plastics people, and they work their magic, and eventually patients can breathe through the nose. So that looks really great.
Yeah, I love how you did sort of a cervical facial on the outside because I think that looks so much better than a giant thigh, especially in patients with darker skin. Like the thigh just looks so like, I don't know, it just, the thigh and the face just have totally different colors. So, and I find that any sort of color match techniques that people have described for darker skin don't work as well on the ALT or don't work as well for people with darker skin. So I think it looks really good.
Yeah, I agree. And Dustin, I don't know if you have comments about it.
Yeah, like Ben had mentioned, thanks, nice presentation, Ben. I know we talked, obviously this is a soft tissue turn ward, but one of the things that one of my partners, Chad Zender, had taught me and I think works really well, and Dr. Abiar, I know you do the same thing with the wire passing burr. If we were able to save the orbit, we've had several cases where taking the floor of the orbit, we're able to use a TFL, and in a similar fashion, instead of using plates and obviously the complications that can result from that, we're able to actually suspend the globe really well and make sure that you don't have any globe malposition with the TFL, and we found that that's actually worked quite well too.
The other thing that really works well, I have not used it, but it's used a lot at Emory, I think, is they basically take the temporalis and I think they take the coronoid and just use the curvature to recreate the inferior orbit, and that works really, really well. I mean, they have pretty good data on it, so.
Awesome. Well, I love the discussion. I'm going to move us on to the next case just because we are at 20 minutes. So I'll have Dr. Farber pull up her case next. We'll work our way down the face. Yeah, I'll mute myself now.
Can you hear me and see my presentation? Perfect. Hi guys, I'm Nikki. Great to see so many familiar cases. I'll be presenting a case that Dr. Carey and I did not soon after starting fellowship here at Penn, and it'll be a reconstruction of a columella. So our patient initially presented with about 1 month of nasal pain and nasal congestion. She also noticed tenderness and fullness at the base of her nose. Her past medical history was fairly unremarkable except for her smoking history. And her exam at the time of her presentation was notable for fullness of her medial crura on both sides and she had about a 1.5 centimeter mass at the base of her caudal septum that extended onto her nasal floor bilaterally. She already came with a biopsy that was consistent with invasive squamous cell carcinoma. Let me see if I can play this. And she came with a CT sinus with contrast. And as we scroll forward, you can see a 2 by 1 centimeter mass anteriorly, without any bony erosion of her maxilla, which you can appreciate on the bone window. So she underwent a radical resection of her nasal columella skin. A good portion of her septum was taken as well, and then her nasal floor bilaterally. And this is a picture of her little tumor. And this is a picture of her reconstruction, or her defect rather. And we recognize that this is a small defect, but we thought, though small, it added a lot of complexity, and is sometimes the smallest defects are the hardest to reconstruct. And thought this particular defect was fairly difficult for a variety of reasons. One, it was a 3-layer reconstruction with nasal lining, septum, and skin. We wanted to maintain the projection of her nose, but we also recognized that putting in a huge flap could decrease her nasal airway significantly. So after a lot of discussion, we ended up going forward with a small radial forearm. So you can see here that we harvested a really tiny forearm, and then we parachuted the sutures into the nasal lining. We actually deepithelialized a triangle of the superior component of the skin flap that was inset to the cranial component of the nasal cavity that was missing the nasal lining. And then this was her reconstruction when we were done. And you notice here we put 2 nasal trumpets in that we cut in half. She had a pretty tiny nose, and we were worried about any compression on the skin paddle. So we cut them in half in hopes that it would prevent any nasal stenosis. And then this was her at the end of the case. And this is a profile view that demonstrates pretty fair maintenance of her nasal projection. She underwent an uncomplicated course, was discharged home fairly soon after. Her nasal trumpets were removed on her first post-op visit. Luckily didn't need any adjuvant therapy. And then she's going to come back in 3 months after surgery so that we can discuss a secondary reconstruction to maintain her nasal projection. And I'll take any questions.
Yeah, thank you. I thought that was a really interesting case when you brought it up. Very challenging. I'm very curious to see what people would do. I think you guys did an amazing job getting that flap in there. Yeah, I guess my first question, because I know the septum, a significant portion of septum was missing, but is it just like forearm on forearm folded, or did you put anything to like that to replace the cartilage or to support the dorsum?
Yeah,
And,
it was just
and then why the decision to not use cartilage?
Yeah. It was just forearm folded on itself. We initially planned to harvest a little slither of bone, and we did harvest a little bit of osteocutaneous forearm with the flap, but it was really tight, and we didn't want to compromise the soft tissue. So we ended up not using the bone, with just planned for letting the soft tissue heal and then coming back after whatever adjuvant therapy she may have needed. Luckily, she doesn't need any, so we're going to move forward with a secondary reconstruction if we feel like her projection's starting to fall.
Yeah, Nikki was trying to make us look good and say that we didn't try that initially. So we harvested this like little toothpick from the radius, and we really intended for it to line up perfectly. And it ended up just like not allowing us to fold it right. And then we had the patient consented for cartilage too, but that pocket, the folded radial forearm on itself, that pocket was basically just the pedicle. And it just was a lot to like try to stuff in there, and closing it around the sort of the nasal sill was really tight, and we kind of worried about more material in the center compromising the pedicle.
And then what's the plan when the tip starts to dip down? Like, when are you going to pull the trigger in terms of secondary reconstruction, and what are you thinking about doing?
I think that's a great question. I think we would probably raise her nose up similar to a second, rhinoplasty, and insert some heart from cartilage from her ear. I think that would be probably my first step. She doesn't have much cartilage left in her septum. She's on the older side, so I don't know if I would jump to rib cartilage right away, but see what everyone else thinks.
Yeah, I think a bony forearm would be really tough. You don't have a lot of ability to put the skin exactly how you want it. That bone really limits you, so I can totally see why you ended up chucking it. It's, yeah, super tough reconstruction. There was no connection to the oral cavity, correct? Like you didn't have to go through the premaxilla. It was just the nasal floor a little bit.
Yeah.
Okay. And then you tunneled your pedicle through the just cheek?
Yeah, through the face.
Nice.
You can kind of see a little incision there, and then we just had a little tunnel through the face, which worked out quite well.
Would anyone have tried any local flaps? I'm just thinking outside the box here, like with like a melolabial turned in the other way, or
I actually have this case come, literally almost the exact same thing coming up this week, and I was gonna try to do a local. Well, I haven't consented for like everything. It's just so hard with all the different challenges, and I also find that like in my experience, this kind of nasal reconstruction just ends up looking so bad, and they're always so unhappy, no matter what I've done. So I actually had a guy where I tried like similar nasal reconstruction, and he collapsed. He had to get radiation too. So I ended up literally just cutting his nose off and him getting a prosthetic, because they can make really good prosthetics. Although those can be really expensive. And I just find that like I struggle so much with these nasal recons to make them look good.
Especially a small defect. They're so much harder to do, and even you could argue for a prosthesis here, right? Someone could create something that's close enough, but at least there's now a good base of soft tissue if you ever decide to put something in.
Totally. I think it's smart that you kind of talk to her about coming back and revising if, once you see how she heals and, improving function with her nasal airway and everything. And I liked how you cut those trumpets in half. I thought that was really smart too. I probably would have just stuffed one in and left the other side. I don't know. So that was nice to see.
I think I was going to just say, I think Nikki maybe mentioned it, but one of the key things was doing kind of parachuting of all the stitches because we were working through such a small aperture. And so we parachuted, maybe, I don't know, 5 to 10 stitches on both sides before we started tying them down. And because the second you put in a stitch, you were kind of blind once you tied down the knot. So that was kind of a key thing. And I think one of her pictures sort of showed that. Kind of like what you do for oropharynx recon and things like that.
I think this case also brings up a good point for people starting out, in that any cosmetically sensitive flap, it's not a one and done. And I've noticed this over the years, end up taking patients back more and more for, let's say, parotid defects or nasal reconstructions, just to touch things up or to deal with the changes. And I think that's important that you prepared them before, that it's not a single procedure. It's going to be multiple procedures over a long time.
Totally. And then I see a comment from Sam about using a like mostly fascial ALT, a little bit of skin around the perforator, and then using a PDS plate. Where is the PDS plate for the septal part, I guess, or where would you?
Yeah, so you can wrap the PDS plate in fascia and use it for the anterior septum, with or without additional cartilage or a small piece of bone maybe, and then the rest of the fascia to do the lining of the nasal cavity, and a small square of skin around the perforator kind of tucked up to reconstruct the columella. The patient I'm thinking of also had about 7 surgeries, so no matter what you do, it's gonna be a long road.
Yeah, super challenging, but great job thanks for sharing that case. Are there any other comments about anything else to consider? Well, if not, I'll have Andrew pull up his slides.
Good evening, everybody. All right, perfect. I am going to be presenting on a lower lip and oral commissure recon. So the patient's a 44-year-old male, past medical history of type 2 diabetes and hypertension. He's a current smoker for about 6 years, and then he also had a history of betel nut and tobacco chewing. But in February, he noticed like a little small pimple, as he called it, on the right side of his wet lower lip. So he went to urgent care and they gave antibiotics, of course, but that didn't help. And so then he ultimately came to the ER, where he's complaining about 10 pounds of weight loss. He had trismus, which was impacting his eating and his speaking, and then ipsilateral atalgia. And then in the ER, he had a biopsy, which demonstrated invasive P16 negative squame. And ultimately, this is what it looked like. So about a 3 centimeter exophytic mass involving his gingival labial sulcus. It's tender. It was kind of involving the skin without like true epidermal involvement. It spanned about a 1/3 of the lower lip, and then didn't involve the commissure, but otherwise a pretty normal exam. So here you can see his CT, and what you'll notice is this mass on his right lower lip. It measured about 2.9 centimeters, involving the buccal soft tissues, the gingival buccal sulcus, and then extending just in the dermis. It butts the mandible without any bony erosion. He didn't have any lymphadenopathy, and a PET scan was done, and that was negative. So here's what he looked like. Day of surgery on the table, with a planned resection of this right lower lip, his oral commissure for margins, cheek, and then chin, and then a neck dissection on the right, levels 1 through 4. And then this is what it looks like resected.
I just want to pause you there before you give away all the good stuff, and see what people's initial thought is on the defect. What components do you need to reconstruct? What would you prefer to do if you can do it? Thinking about, local and free tissue, and we're seeing a lot of buccal mucosa gone here, obviously a lot of skin gone, lip. So a few different components to think about.
No, this case gives me nightmares. I had this exact case where we put, I think, 3 flaps up on a guy and none of them survived over a 48-hour period because of some vascular disease we learned about afterwards. And this is a tough defect if you have to do local flaps. It's really tough. Yeah.
One thing I would mention is that I see the neck dissection incision there, and I wouldn't do that incision, I don't think. I would probably drop a limb down from the existing defect so that I had the option for a cervical facial that had a larger bridge. So that's one thing that I'm thinking about, seeing this defect with a neck incision not yet made.
Do people try to save their facial artery, just for blood flow to the lip and to the surrounding area? And if you were doing bilateral necks, do you take that into consideration when doing level 1, or not really? You rely on collateral or other flow?
I should think about it, but I don't.
This doesn't matter then. So,
Yeah, yeah.
yeah.
I think, this is a tough one. I'm glad I'm not having to recon that right now, but I find that it's best to try to reestablish the oral competence as much as possible, but it ends up making such a small mouth that makes surveillance and eating really hard. So that's one of the challenges to balance with the lip recon on the outside.
Perfect. Well, let's see what you did next.
So just quick picture of the specimen. Here's like externally with this little commissure, and then this is like the internal view with the commissure there. But ultimately, we used local flaps for external closure. So we did a left-sided Karapanzak and then a right-sided S-lander. But ultimately, to get internal lining, we used a forearm. So you can see kind of it's like sewn in here from below, and then it gets flipped up, and then have the pedicle coming down. And then, as alluded to, I guess perhaps not as well demonstrated in that prior picture, but we did ultimately employ a cervical facial advancement flap to close that remaining aspect of his facial wound. So here's what he looked like, all closed up. And ultimately, it was a 4 centimeter tumor with 3.2 centimeters DOI. We had some close margins, but they were anatomically limited sites. So periosteum, which was cleared off, but nothing clearly in the bone. And then we had a soft tissue margin where it approached the gingiva, but ultimately all that mucosa was resected. So here's what he looked like on day 11 post-surgery. We successfully started PO on day 5 and didn't have any problems there. And then he was ultimately recommended CRT for his close margins, but he wanted only radiation. And then on his 29th fraction, he decided he did not want his last dose. So we saw him a couple weeks ago, 2.5 weeks after surgery, and here's what he looks like, kind of all healed up, and he's got good kind of gingival labial sulcus, which you can kind of see in those pictures taken with the scope on the left side. But he's tolerating PO and has fair opening and doing well.
That's awesome. I think sorry, go ahead. Were you
Go,
gonna?
please, Marianne.
Oh, okay. I didn't know who was, sorry. No, I was gonna say, I think this really highlights nicely like how important it is if we can get the lip closed back up to lip with rotational flaps and local tissue rearrangement, you know, we should, but of course the limitations with, as I think Maddie mentioned earlier, with mouth opening and exam and keeping your teeth clean and, you know, all that. But really nice job here. What were you gonna say, Jason?
I was going to add that, you know, this was a great balance of the trade-off, right? You know, he's narrowed, but it's not terrible. He has function. He's able to eat. So I thought this was a great case because you're able to balance everything.
And then the free flap for intraoral for the buccal mucosa hopefully can then prevent any further trismus or restriction that you would get, you know, if you hadn't put that there. I think you needed that for sure.
Also with these beetle nut chewers, and he's 44, like he's at such a high risk of recurring. I had one of these guys and it's just literally like playing whack-a-mole. So like it's really good you're able to see in there to surveil them.
Does anyone, I know this wasn't in this example, but does anyone have any tips on if you do need to put your free tissue for the lower lip or the commissure, like what do you do to support that free flap, whether it's a forearm or whatever you choose? What do you do with do you take tendon or fascia or?
I take tendon or fascia and try to sling it. Obviously it doesn't function as well, but you have to sling it like really tight because that'll loosen with time.
And then if you're using a single flap going from internal to external lining, right, it's almost like a diaper. You want to go wide inside, narrow across the lip, and wide outside.
You would always
Right.
say that. You'd say that when we were reconning, and I'd be like,
Right, it works great.
out.
I've never
But
heard
now-
it, but I want to know more.
No, so right, if you have a through and through defect, including the lip, right, and you don't want to narrow their oral opening excessively, right? You go wide on the flap outside, you go wide on the inside, but then the part that transverses the lips, you deepithelialize aggressively, really, you're going wide and then narrow, and that narrow part with the extra soft tissue allows them to seal the lip because it's maybe 2 or 3 centimeters. That's a non-sensate and non-mobile portion. So they can still open wide enough to get food in, but they're still able to seal so they're not drooling constantly. Yeah. I never showed you any of these in the 5 years you were in Miami.
I don't remember now.
I can't.
I remember
forget the
every
diaper
case we did
I
together.
can't remember what I did last year anymore. Lindsay, beautiful case. That was your case, I think. I don't know if you had any other comments on the challenges or, you know, anything else you were considering.
Yeah, thanks. No, I mean, it is challenging, and I'd had a very similar defect in a patient who but also had a segmental mandibulectomy, and we'd done a fibula for, and she had, I think, more skin resected than we had originally planned. And so we were trying to reconstruct the whole thing with the free flap. And it really didn't come out as well. And, you know, her back for local flaps. And so with this patient, sort of and then using the free flap for he's happy, his function is really good. Definitely learning experience. We had talked about for this case and for a similar case was read about but haven't seen. Does anyone have experience with that as like a functional
I can't tell if you're breaking up for me or if it's me, if it's my computer. Is it me or is it Lindsay's?
It's her.
Okay, I'm sorry.
Okay.
I caught some of it, but I didn't catch your question at the end. You were saying if anyone has
sorry,
any.
probably me.
No, it's okay. You were kind of like cutting in and out and it was like speeding up and slowing down. So, were you saying like if anyone uses the free flap or I didn't hear the last question to answer. I don't know if anyone caught it. But one of the things, I think she's frozen now, maybe. One of the things I was going to bring up is that something I saw in training was
thinking about a functional gracilis.
Oh, about functional gracilis. Yeah, super interesting question. I've never done one. I don't know if I know Leibowitz now, you guys have a bit more like facial reanimation with Lily being there. I don't know if you guys are doing that now.
We'll use gracilis to reconstruct the lower lip because of the color match and the size, but we haven't plugged it in. So in terms of nerves,
interesting.
it's not a bad thought. I guess the question is how will it coordinate, you know?
Yeah, and then for total lower lip, I've used free flap, like a forearm out of lack of better options, I guess, depending on how much chin and other skin is missing. And we used a tendon passer and actually like 360'd the tendon. So it was like you could, I know Nikki has an example of this too, but theoretically you can like purse the lips with that tendon passer and connecting the tendon to itself. So I thought that was another option. Well, awesome. Does anyone have any other comments? Anything else they would have done? Great. Any questions about any of these cases from any of the fellows on here? Happy to, we have a little bit of time if anyone wanted to discuss anything else. Otherwise, we've done our 3 cases.
Marianne, this is Don. The only comment I would add, having done this for a long time, is I don't feel like I have to be the expert at every part of these very complicated reconstructions. And I have a very low threshold for partnering with my facial plastic surgery colleague. These last 2 cases highlighted where someone with a lot of experience with smaller lip recon could really be a useful partner in the operating room, even more so with complex nasal recon. So just would say that the microsurgeon and the facial plastic surgeon, if they're not the same individual, really can often do better together than each one separately. Just a editorial comment.
No, that's a great point. And even with the first case with, I know we brought up like an oculoplastic surgeon, depending on your institution and who you can collaborate with. But yeah, really good to think about. Well, perfect. Thank you all so much for logging in. And I know it's later on the East Coast, so really appreciate your time. And thank you to our panelists and our experts. Yeah, thank you. Have a good day.